Okay, so first and foremost, welcome everyone. Thank you all for joining. Thank you, Dr. Kahle, for joining. I just want to quickly state that this information that's presented today or during this session is not intended to be a substitute for professional medical advice. All content is for general educational or information purposes only. Our guest is not compensated for his time, nor does the company as a whole receive preferential treatment. And Dr. Kahle is generously sharing of his time, knowledge, expertise, and experience on this very important topic. And with that being said, I'll just quickly introduce Dr. Kristopher Kahle. He is the Chief of Pediatric Neurosurgeon at Massachusetts General Hospital and Director of the Harvard Center for Hydrocephalus and Neural Developmental Disorders. He is an investigator in the Division of Genetics and Genomics at Boston Children's Hospital and an associate member of the Board of Institute at Harvard and MIT. He is a board certified neurosurgeon and specializes in the treatment of congenital abnormalities of the nervous system, and a world-class scientist with three national institutes of health grants whose lab studies the genetics and mechanisms of the disorder he treats, hydrocephalus in particular. So with that being said, Dr. Kahle, I'll turn it over to you. And if I said anything incorrectly, please correct me if I'm wrong. Thank you again for joining us.
No, not at all. It's a pleasure to be here. Since pediatrics is definitely my passion, and was trained in pediatric neurosurgery fellowship at Boston Children's, but my practice and my interests are not restricted to kids, because kids get older, even kids with genetic diseases. And I think this is one thing I want to really get across to this group, and really anybody else who's listening to this, is that there's a really unserved need for patients with these disorders as they get older. And in fact, there's a whole host of new challenges that arise when folks kind of graduate out from pediatric hospitals. And so that's why I think that being a pediatric neurosurgeon in a general hospital means that you take care of patients with these disorders across the age spectrum. And so I don't want to, restrict this to only kids, although I love kids, but kids get bigger too. And so I'm very interested in helping out across the age spectrum.
Excellent. Thank you. So I do have some questions first and foremost that, I've already lined up, and I'll start with the diagnosis of the condition. So does X-linked go undiagnosed in girls that have developmental disabilities from your experience?
Yeah, I mean, so if today we're focusing specifically on L1CAM syndrome, this is an X-linked disease, and therefore overwhelmingly transmitted from male to male. And the overwhelming majority of folks with this syndrome, of which hydrocephalus is a predominant part, are males, and that results from a so-called hemizygous mutation state, where you have a Y chromosome and an X chromosome that then also carries the mutation. Girls, for that reason, usually are unaffected because they have a normal copy of the gene, which can kind of take control and take over. But in some circumstances, even females, this is very rare now, but even females that are so-called heterozygous, meaning they have the mutant, pathogenic allele on one of the X chromosomes, can sometimes display more subtle manifestations of CNS involvement. So intellectual disability, developmental delay, these sorts of things are much less severe than males with the disorder, who usually have profound or can have quite profound both structural and functional brain abnormalities.
Yeah. So how can the L1 gene randomly occur? Is there anything that triggers the mutation? Like, family history or no family history?
Yeah, well, I mean, this is an excellent, familial form. Frankly, one of the few rare familial forms of hydrocephalus, meaning that, in an extended family pedigree, there will be multiple affected individuals that span generations. And it's also very easy to note if you have that extended pedigree that only males are being affected. So those genetic findings in concert with the very characteristic phenotypic manifestations make the diagnosis, even without a gene mutation, sometimes pretty easy. Um, why the genes get mutated in the first place, that is a fundamental genetic question that we really don't have a great understanding of. We do know that in addition to transmissible mutations, going from one generation to the next, sometimes, during the course of development, so-called de novo mutations can occur either in the egg or sperm before fertilization happens, and that can elicit sporadic cases. So, folks with sporadic congenital hydrocephalus, this is a fundamental point I'd like to make, do not necessarily not have a genetic cause. You can have a genetic cause even if you're the first person in your extended family over generations, because so-called these de novo mutational events occur. And there's a lot of speculation about what causes these de novo mutations, whether it's environmental exposures during pregnancy or just frankly chance mutational events. We know that, during DNA replication that these sorts of events occur randomly by chance. And, if that mutation hits the conserved residue in a critical protein, encoded by a gene like L1CAM or some other genes that my lab and others have discovered, it can lead to the phenotype. But that's, if you have the mutation, it doesn't mean you certainly did anything wrong or that you are responsible for it. Even, if you, I think that's a very common fallacy, not fallacy, a common, what's the word I'm looking for? Feeling, maybe that mothers and fathers have during, these sorts of pregnancies and then after birth, where it's come to light that something like this has happened. It's not anyone's fault. It's something that happens, and then a main privilege of my job is to see how families rally around these situations, and to see how lovely a lot of these children, when they're affected, turn out to be. And so that's a huge bonus of my job, is dealing with families with these disorders.
Yeah, I definitely, when I do get calls in, they're very concerned and they're always asking, like, do I go to a geneticist? How do I figure out if I have, that gene or that mutation? So that's a very interesting, that's good to know. So at what gestational age or at what stage in pregnancy does the L1 gene show up if it is actually genetic?
Yeah, well, I think probably one of the biggest realizations, or revelation would probably be too strong of a word, but some insights that we found from studying the congenital forms of hydrocephalus is that, first of all, and L1CAM is one of those, is that for anyone who has congenital hydrocephalus, about a third of those patients are going to have a genetic cause, a mutation in a gene that you can discover by, now pretty standard next generation sequencing techniques like exome sequencing. And so, so first, that genetic causes of hydrocephalus are very common. So the question is, how do those genes cause the disease, and when do they occur? The cool thing now is that through many of the big data um, uh, projects that have been going on in multiple labs, is we really have a catalog or a atlas of where these genes are operating in time and space. So across the developmental spectrum, what stage of development these genes are highly expressed in, and then also not only when but where, and not only by brain region but down to single individual cells. This has
Yeah.
really been the boon of single cell RNA sequencing technology. So what that data has really revealed is this so-called integrative genomics. It's really shown that these genes that are involved in multiple forms of congenital hydrocephalus, including L1CAM, impact very early aspects of not only brain development but even neural tube development very, very early on. And so, usually not only that can really account for the fact that in many of these patients, as a neurosurgeon, we think of L1CAM, disease as hydrocephalus, and this is the Hydrocephalus Association, right? Talking about this disorder, and rightly so, because for many of these patients with aqueductal stenosis, of which is really the cause of hydrocephalus in the majority of L1CAM patients. That's just one facet of the disease, and so it's a fluid disorder, no doubt about it, but it's not just a fluid disorder. It's also a brain disorder, a parenchymal brain disorder, and so that's a challenge because as neurosurgeons, as my 13-year-old daughter likes to remind me, I'm just a brain plumber in these situations, trying to come up with a fluid solution to this problem. And to our credit, it can be life-saving. And so that's an important intervention. But the issue is that I think as neurosurgeons, we admittedly, and maybe necessarily given how, the limited technology we have available to us, we have a pretty low bar for, treating this disorder. It's mainly, putting in a shunt, or in the case of L1CAM, I love to use endoscopic third ventriculostomy when possible to avoid shunt placement because of the presence of aqueductal stenosis. And of course, again, that's life-saving. But in terms of, I think a lot of neurosurgeons, including myself, I think that once we know that the shunt is working or that the hydrocephalus is treated, we kind of wash our hands we're all done. This is, we've done our job, but that really doesn't address, I would say, some of the long-standing and perhaps more fundamental issues that are going on in the brain itself, in the brain parenchyma, outside of the fluid space. It's not just the ventricle and what's in the ventricle. It's the most obvious, maybe, because the ventricles are huge, and it's what everybody sees, on the MRI. And if it's a T2 weighted image, it's white and bright, and it captivates your attention. But it's really the functioning of the, or dysfunctioning of the thin brain parenchyma that is causing a lot of the other persisting phenotypes like seizure disorder, the developmental delay, and some other things which shunting really doesn't address. And so the reason why those brain parenchymal issues are occurring is because these genes are functioning so early in development. They're not only impacting aqueductal development, they're also impacting the way that the neurons are developing, the neurons are connecting with one another, and the way that messages are being sent from one neuron to another. So long-winded way of saying that these genes are impacting not only fluid, but also brain, and doing so way early in development, which is the reason why you have a lot of severe phenotypes.
Mhm. So speaking of just like long-term impacts and with they're already impacting in the developmental stages and things like that, talking about complications in the long run, overall health, or quality of life. When do you have you experience and with your patients, when do things start falling apart? Are there GI issues that make it a marker, like you see different levels of complication that kind of say, okay, this is starting to progress more? Um, that's a difficult question for most parents, of course. Yeah.
Yeah, I think in part it depends on, there's a in L1CAM, although it's a bit fuzzy as it is for a lot of these single gene disorders, there's not exactly a very tight, what we call a genotype phenotype correlation. So we do know that, if for some pathogenic variants, I'm talking now about the types of mutations you might have in L1CAM. So L1CAM is a big protein. It's encoded by a large gene, and mutations can fall along, many different points along that gene. Depending on what the type of mutation is, maybe it just changes a single base, so-called missense mutation. The phenotype, or the way that the disease manifests, may be less severe than a type of mutation that truncates or chops off, a large part of that protein by, introducing a premature stop codon, for example. So the point is that there are some correlations that can be made between what gene mutation you have and the type of how severe the disease is going to be. But even within the same family, I've have of course a bunch of L1CAM families that I take care of, and one of them I remember very well. Of course, when you're dealing with multiple affected siblings in the same family, by definition, they're going to have the same mutation. But that doesn't mean that the severity of two brothers, you can have quite profound variability in the phenotype between even two brothers with the same mutation. And
Mhm.
so the question is, well, what accounts for that? There's probably other genetic modifying influences from other genes, and also environmental exposures. And so I guess fundamentally, how severe someone's disease is not only dictated by the genetics, but as probably a lot of people know on this panel, um, the types of things that the kids are exposed to, even in the hospital, shunt malfunctions, complications. It's just, I feel like, each stay in the hospital is almost like can sometimes feel almost like a minefield, where you're just trying to escape getting a major hit from a complication, and surgery is like that in part. We like to say, and it is true, if you take all comers, that a lot of our procedures are low risk, but when it comes to neurosurgery, especially in little kids, those risks are actually much higher, and they're much higher because these kids have multi organ system involvement. Their immune systems are weaker, which means that they're more susceptible to getting an infection, even from a simple procedure. And then sometimes for reasons we just don't understand, their physiology, undoubtedly driven by their genetic influence, is just unpredictable, and so it can create a real challenge.
Yeah. Is there, and I know you said some things are unpredictable. Is there a way to determine the severity of the mutated gene and possibly the lifespan?
Yeah, I mean, so as these kids are getting older and older, we're starting to collect more natural history data, um, and also making tighter genotype phenotype correlations. So I think a big project that would be extremely worthwhile, and I mean, maybe I'm sure parts of it exist, for a couple of other L1CAM experts out there. But I think one of the issues is that you have these kind of fractured biorepositories of, all right, we have a case series of this many patients over here, we have a case series of this many patients over here, and sometimes for a very rare disease like L1CAM syndrome. It's tough to make tight correlations when you don't have a lot of patients to look at.
Mhm.
And that's compounded even more so when you just have a very rare disease. So compiling all that data together in a way in which you're able to look at both genotype, phenotype, and then neuroradiology all at the same time, especially in the age where you can notice patterns both on scans and on the electronic medical record through artificial intelligence and other machine learning technology, would probably be the best way, to make those links so that, maybe at the time of birth, when this is discovered, you can gain, allowing parents, for good or for bad, to understand the full prognosis of what they might be able to anticipate for their child, and then of course for their family dynamics would be the goal. But that's imminent. That's happening, and will, and will continue to happen.
Oh, that's great. Does gene therapy, if you can explain a little bit about gene therapy, does gene therapy help or stem cell therapy help with L1CAM?
Well, neither of these are available right now for L1CAM, but I'll tell you, if I had to pick a potential gene for targeting for hydrocephalus, congenital hydrocephalus, I think L1CAM would be at the top of my list, and I think that's one of the things that my lab and I'm sure other folks are considering now, because this is a gene that could be potentially replaced, because these mutations that are impacting L1CAM function elicit something called a genetic loss of function. So the idea, at least in principle, is very straightforward, in the sense that the goal of any sort of gene therapy would be to replace the mutated protein which doesn't function with a so-called wild type copy or normally functioning variant. I think the challenge, so this is being done in some other single gene disorders right now, as with the advent of CRISPR gene editing technology and other gene editing techniques, and some of these are being accomplished, of course, in the postnatal setting. And so the question is if L1CAM is impacting very, very early aspects of of uh, of neurodevelopment, during fetal development, how would you go about doing that? And so that raises, of course, a host of ethical concerns that really need to be thought out and deliberated upon before engineering it. But in principle, correcting that defective allele of L1CAM early would be a potential strategy to mitigate or potentially even cure, the condition postnatally.
Mhm. Thank you. I know I asked a lot of questions, so I want to give everybody an opportunity to kind of, if you need them to go back and refresh and or like expound on any of those questions or answers. I know Leslie had a question, so I will allow you to go ahead and present it to Dr. Kahle.
Hello, can you hear me?
I can.
Okay, good. So I am 73 years old and I had two brothers. My first brother was born in 1940 and he lived 6 years. He had severe hydrocephalus and he was spastic quadriplegic, blind, deaf, everything that you can, add to it. They did like a makeshift shunt then. They knew nothing about, they just called it hydrocephalus. Then my second brother, my first brother died before I was born. My second brother was born in 1943 and he was 7 years older than me. And he lived till, I think he was 40 when he died. He did not have hydrocephalus. He had what they just called cerebral palsy. Then I also had a bunch of cousins who were males who had hydrocephalus. And I spent my whole life in the field of disabilities because of that. And I have just been, since the internet, I have been searching for answers. And I know that's crazy, but I just want like some type of closure. And then I came across L1CAM and it just all fit. And I'm just wondering, because of so many in our family, does this sound like L1CAM? I mean, is X-linked hydrocephalus always L1CAM?
No, in fact, there's other X-linked forms of hydrocephalus, and they're driven by mutations in other genes that are on the X chromosome. So,
But because my one brother did not have hydrocephalus, that's
well,
why.
it doesn't rule it out, because as I was alluding to before, even individuals with the same mutation in L1CAM, the way that their disease presents can be quite variable. And so even within the same family, even siblings, and those factors I alluded to, but are very poorly understood, what accounts for that so-called phenotypic heterogeneity. But I mean, do you have any living relatives with hydrocephalus, or you think that are affected in this extended family of yours?
Not anymore. They all passed away. And then my sister and I ended up adopting. So because we didn't, in those days, there wasn't like amniocentesis and we just ended up adopting.
Yeah, well, I think that if there are, you can email me. You can find my email online very, very easily. In fact, you can go to our lab website, has a little portal you can enter yourself in, and this is all secured and IRB controlled and
Oh, that's
stuff.
okay.
Potentially by drawing out the structure of the pedigree and sequencing, some individuals, including yourself, that we might be able to, obviously you're not affected, but as a potential, carrier, we might be able to kind of piece that together. And if that's something that you're interested in and could help, reconstruct the pedigree,
Hmm.
I think we could, potentially help out with that.
Yeah.
We're very enthusiastic about trying to get a better understanding of what these
Yeah.
mutations do.
My brother who did not have a hydrocephalus had like abducted thumbs and he had,
He did
uh,
have abducted thumb.
yeah, he
I
did.
mean, I would, we're renovating right now, so maybe not the best way to put it, but I'd bet my house on the fact that, this is probably L1CAM, but we could potentially sort out
Yeah.
um, the precise
So it
mutation.
does sound like it.
It does sound like it.
Yeah. Okay. I just went, it's just, I have been, wondering because nobody else in my family they just slough it off, and it's like, I've just been researching ever since the internet and came across this and it just sounded so much because there's 4 different types or whatever. Yeah. And both brothers fit into, a different one.
Yeah, it might provide, yeah, I'm sorry for all the, that situation. And on the other hand, it sounds like it's inspired your own life's work
Oh, yes.
which is
Yes.
totally awesome. And that's
Absolutely. I got a master's degree in special ed. I ran a school for kids with severe disabilities.
yep.
Then I started an early intervention agency all across the state of Missouri. And
Wow.
that was because my parents had nothing in those days. There was absolutely nothing. The doctors would say, put them in a home and forget about them.
Yeah. Yeah. Have been remarkable improvements,
Oh,
still far
yes.
from perfect, but
I've seen a
yeah, just
revolution.
contact us, through online.
Okay.
We'll get back to you.
Thank you
And
for listening to me.
thank you,
Problem.
Leslie. And I put in the chat, Dr. Kahle, I grabbed from our website. Hopefully that's the one that you're
Yeah.
talking about. Okay.
Yep.
Thank you.
Sarah, thank you, Leslie.
Well, yes, every time when I hear about like Leslie's brother dying at 6 years old, I'm kind of horrified. What do L1CAM patients die of? Is it always a shunt complication, or what do they die of?
That's a great question. It, I think hydrocephalus is a big one. It can be in the context of the reason why hydrocephalus in this context is so dangerous is because um, hydrocephalus comes in a bunch of different versions or flavors, and the one associated with L1CAM syndrome mostly, actually almost always, is an obstructive form of hydrocephalus. That's in contrast to communicating forms, which are less dangerous. Communicating forms of hydrocephalus also known as non-obstructive. Again, that this terminology is just murky at best, but it has some functional weight in the sense it tells us sometimes how urgent or how fast you need to treat this because of how severe it is. So communicating means that there's no obvious blockade within the ventricular system to CSF flow. Whereas obstructive hydrocephalus, as the name connotes, there is a blockade, and in L1CAM patients, that blockade occurs at the level of the aqueduct sylvius, which is, for anybody who knows anything about brain anatomy, it's like a funnel that kind of comes down into very thin a thin exit point. It's right at that funnel, that critical bottleneck, so to speak, that can get stenosed, or really just a fancy word for narrowing, and then completely occluded. So it's like, putting or building a dam in front of a river, right? You know what's going to happen upstream. And when you have fixed cranial vault, that's a problem, right? Because increased volume increases pressure, and when you increase pressure up to a certain point beyond the compliance of the brain to accommodate it, you can cause something called brain herniation. And brain herniation is when parts of the brain are displaced to such an extent that they permanently cause impairment of neurologic function in critical brain areas like the brainstem. And so that can happen, and that can happen actually pretty fast. And it's not to freak anybody out or to be an alarmist, but it's just to say that if you are if you have a shunt and you suspect shunt failure, and each kid presents a little, each person presents a little bit differently. That's why we take it so seriously, especially in these settings. But that's not only the cause of death in these patients. There's because there's structural brain abnormalities in other parts of the brain, like the brainstem, outside of the hydrocephalus pathology. You can often get a respiratory, disease and say, in a normal kid, they might get RSV or a pneumonia, and you might even have a serious case. But you usually get through it and get over it. But when you have such a lowered capacity to deal with these sort of insults or perturbations, even common illnesses can really prove to be quite dangerous and sometimes even fatal in the context of serious syndromic disease.
Thank you. Any other questions from parents, or feel free to share?
Yeah, I would just like to make myself, available to, folks, who, another question comes up and you might, or you might feel uncomfortable about, asking it in a context like this. The best way to get a hold of me is usually by email. It's online. Just search my name and MGH, and it'll come up, and whether it's for clinical questions or just who knows what questions. This is definitely a passion of mine, and I'm always willing to help out, at least to the extent that I can.
Sarah, you had another question?
Yes, I've got another question. Early on, you talked about ventriculostomy or things like that. I don't know the proper English word. I'm German.
I'm German too. Kahle, or Kahle, I think is how you pronounce it.
So would you always prefer this kind of surgery to the shunt?
I do. I love it. The reason being is the reason is obvious. It's you can usually do the procedure in about 15 or 20 minutes, if you're not waiting for anesthesia. And kids do great, and you can avoid shunt placement. And the aqueductal stenosis is really a kind of a sine qua non for using that procedure. What the endoscopic, a very long-winded term, endoscopic third ventriculostomy, we'll call it ETV going forward, just for our sanity's sake. But the idea is instead of putting a tube into that fluid space called the ventricle and then channeling it or diverting it to an alternative space that can actually reabsorb it, with endoscopic third ventriculostomy, you are using an endoscope, which is just like a real, the caliber of it is actually very similar to this pen that I'm holding, maybe a little even smaller, some of the small scopes we use. And it has a cool little camera at the end of it. And through the catheter, or through the working instrument, you can pass, little tools to, for example, fenestrate or open up a little hole effectively in the bottom of the third ventricle, which is just a translucent membrane. You can do it with impunity. You're not hurting any structure. And so what that does, that so-called creating a window through the bottom of the third ventricle, it's like unplugging the drain. Or it's trying to think of another analogy. It's not removing the blockade, right? The aqueduct is still stenosed. We can't open that up directly. It's in too critical of a brain region to do that. But maybe instead of removing the dam in front of the river, the analogy would be to kind of create a channel around the dam to get to the other side. And that's what the endoscopic third ventriculostomy does. Sometimes in L1CAM syndrome, the brain anatomy that allows you to do that, to go from one chamber into the next, can be so distorted that despite the fact that there's aqueductal stenosis there, you can't get to the space that you need to, because the anatomy is so abnormal. But usually you can. And
Okay, but
yeah.
up to now, Nicholas doctors never talked to us about such a thing. I don't even know if the hospital we are in with him even does this kind of surgery. So you think it might be a good idea to contact another clinic and ask for a second opinion if it is possible?
Definitely. Yeah, I mean, again, I even just I'd be happy to look at anything or whatever. But I think that's you know, a lot of kids with L1CAM syndrome have aqueductal stenosis, and the treatment for aqueductal stenosis in a lot of cases can be achieved with an endoscopic third ventriculostomy. And so I love doing this. You know, whenever a patient presents to me from an outside hospital, where there may not have a capacity to use the endoscopic option, I always use that new presentation, at least to me, as a potential time to reevaluate and hit the reset and say, okay, what are we dealing with here? I don't, even if they were shunted 10 years ago, are they coming from a situation that at least now we can maybe change the narrative? Can we get the shunt out? Can we do endoscopic treatment and kind of alter the course of things going forward? I of course don't know the specifics in your case, but it would definitely be worth a reevaluation with that specific question involved. You know, quote, you know, is my child an ETV candidate? That's what I would say.
Okay. Um, forgot it.
That's okay. No worries. Leslie. Oh, no. Thank you, Leslie. Appreciate that. So, Dr. Kahle, before we jump off, I want to piggyback on your passions. So, what are you currently working on, and what are you excited about?
Well, let's see here. In lab, as it relates to hydrocephalus, I'm interested in a lot of stuff, including the Green Bay Packers, but they lost last weekend, so we'll bracket those guys. In lab, the things that I'm most interested in now is we have accumulated now thousands of what we call trios. These are parents and children, you know, a biomom, biodad, and the affected, what we call proband, but you know, the patient, little kid with congenital hydrocephalus and other forms of ventriculomegaly, big brain ventricles. And what I'm really interested in, besides you know, finding out the genetic causes of those of what those kids have, is we've got a couple genes that we have found to be targetable with drugs. And so trying to use this, you know, the first phase, maybe the last 5 to 7 years of our work has really been centered on trying to find out what causes, you know, what causes congenital hydrocephalus and other forms of hydrocephalus for that matter, and other structural brain diseases for that matter, and basically anything that a pediatric neurosurgeon would deal with. But we use a genetic approach, and so those are the diseases that we're focused on, at least from the investigative angle. And you know, we're beginning to find that some of these genes are targetable with even existing drugs that are in use for other disorders. You know, L1CAM is not, you know, is not currently targetable, but the point that you brought up earlier about it being a potential, you know, gene replacement or gene editing target, I think is right on the money. So I think pursuing that angle for those genes that are amenable to that approach, and I think L1CAM is a decent example. But then also pursuing some of these postnatal targeted therapies. And I'm specifically thinking about some of the genes in the PI3 kinase signaling pathway that have mutations like PTEN, which causes increased PI3 kinase signaling, and we found in a bunch of our models that this is both the fluid and the neuronal phenotypes can both be made significantly better by giving an inhibitor of that pathway even several weeks after birth. So those pathways are very important for normal aspects of neurodevelopment. So trying to figure out strategies to tamp down the hyperactivated signaling that's causing disease while maintaining maybe a level of activity that engenders normal brain development will be critical. But the idea that we're just not interested in cataloging genes and their mutations, but we're interested in exploiting that knowledge for targeted therapy. That's one thing that we're really going to be centered on for the next 10 years or so. And then the other things I think that are interesting is we're finding that and others have made some of these links as well, that while folks may not have hydrocephalus that requires neurosurgical treatment, the finding of ventriculomegaly or big brain ventricles on imaging, even fetal imaging, can suggest that other genetic things might be going on. And so, we've been finding that some folks with primary ventriculomegaly, though not requiring neurosurgical shunting or ETV, might still benefit from genetic testing because, some of these patients, as it turns out, are carrying mutations in genes that have been highly linked with autism spectrum disorder. And so we're excited about that because, a lot of times, most often, autism spectrum disorder is really not diagnosed until, much later in school-age children. But having that knowledge, even in the womb, you could anticipate needs and therefore perform early interventions in patients with those gene mutations. And patients can get flagged for genetic screening and early intervention and follow-up by the presence of a structural brain marker, such as ventriculomegaly. And that really hasn't been recognized or that link, been firmly established. But I think we have done that, and that data will be coming out soon.
That's amazing. Actually, I just recently spoke to a lady, she's in California. Her two sons have autism, severe disabilities, and she recently was diagnosed with hydrocephalus, but then they went back and looked at her sons and they had, and for a long time, I mean, since birth, I think they're 10 or something like that now, and they didn't diagnose the children with hydrocephalus.
Until it's really,
Yeah.
you should put me in touch if they
I
are,
will.
if they truly
Absolutely.
do. That would be fascinating because that's another kind of proof of principle. But yeah, this happens, and I think the reason it happens is because a lot of people, I think neurosurgeons and neurologists, of course, being those who treat autism disorder, think it's just a training thing. They think a little bit differently about, the brain imaging and when to get it. Whereas neurosurgeons, we just don't make any decision ever without brain imaging. So in some sense, I think we're a little intellectually lazy sometimes. The neurologists are much smarter, while we just rely on the brain image to tell us what to do. And so, but sometimes making those links with the imaging findings in folks that may not have neurosurgical disease can be really illuminating. And the ventriculomegaly in the context of autism spectrum disorder, and frankly, the presence of autism in congenital hydrocephalus folks these are two things that I think are frequent but under-recognized, and they obviously have clinical implications for our patients.
Yeah. Sarah, you remember your
So,
question?
so that was just what I was going about to ask. As Nicholas was diagnosed with autism about the age of 3 years, so I was just curious if there is any known relation between L1CAM and autism.
Yeah, no, I think that it's you know, the clinical definition, you know, of autism. I think there are multiple ways to get to that clinical diagnosis, and you know, whether you're altering neuronal structure, function, the way that neurons make connections with other neurons, you know, synaptogenesis, the way that these synapses work in concert in a circuit, you know, from, you know, neuronal all the way up to the circuit level. This can be influenced in a myriad number of ways, and that's why I think that, you know, L1CAM, you know, through its work in, you know, the extracellular environment, or you know, different ion channels that set membrane potential, or different neural stem cell regulators that lead to you know, that give rise to neurons. You can get there any number of different, you know, any different number of ways, and so yeah, that doesn't surprise me, and it's undoubtedly, you know, related to the genetic defect in L1CAM.
Well, yes, he doesn't seem to have any understanding of what speech is for, and so we're just getting there, but in very, very small steps.
Yeah, but these are important points to make, because you know, when you're, and it's something as a neurosurgeon we have to remind ourselves daily, because sometimes in the setting of when we're evaluating either the need for hydrocephalus treatment or the treatment that we've already employed, how well it's working, these are the sort of inputs that we're taking into consideration. And so it's not infrequent for a parent, usually the mom, to be bringing this stuff up and say, well, we're noticing these delays. Do you think the shunt is working? Or is it working at the proper level? Do we need to be draining more fluid? Do we need to be draining less fluid? And while those are important questions that, you know, require thought, and you know, sometimes the answer is, yeah, we need to do something different in regards to the fluid dynamics. You know, it is often the case that those aspects of the syndrome are really not currently related to any sort of fluid problem. That's why I was talking about trying to make a difference between, or not remembering that these mutations have multiple impact on both fluid and brain itself. And so the brain itself, of course, they're interrelated, but those more intrinsic brain disorders are the ones that are most certainly operative in your you know, for the autism phenotype.
Excellent. So as we come to a close, I would like, if anyone would like to ask a question before I allow Dr. Kahle to leave the room, I give you once, twice, 3 times. Thank you, Dr. Kahle, so much for joining us. We appreciate you spending an hour of your time with us on the weekend. And this was very informative. So thank you.
Thank you.
All right, guys, have a good weekend.
Thank
You
you so
too.
much.
Thank you. Bye.
Bye-bye.
Okay, I put Dr. Kahle's information back in the chat box if you guys want to copy and reach out to him. He is an excellent neurosurgeon. So I hope you guys learned a lot. Thank you so much for joining. Feel free to email me or reach out to me if you have any questions, okay?
Thank you.
Thank you. You guys have a great weekend. Bye. Bye-bye.